Hello, and welcome to an American Academy of Ophthalmology webinar regarding the implementing of MIPS in your practice. This webinar is for those participating in MIPS who do not have an electronic health record, but who report via IRIS Registry through manual data entry or claims. Our speakers today include Ms. Rebecca Hancock, who is Director of the IRIS Registry, Michael Repka, Medical Director for Health Policy, and Sue Vishrilli, Director of Coding and Reimbursement for the Academy. This material is very important. It's important because macro legislation changed the way physicians are paid from 2019 through at least 2026. It's important for all of us to recognize that MACRA is not affected by ACA, and although we've had a recent presidential election in which the repeal of ACA has been forecast, those measures will not affect this program to any large extent. We may see simplification or other fixes to the rigorous detail required of physicians by this program, but it's not expected to be replaced or eliminated. The information that we present today reflects the latest information as of December 2016. For ongoing information, don't hesitate to go to the Academy website at aao.org/MIPS. This recording is copyright 2016 by the American Academy of Ophthalmology, and therefore no part of the presentation may be reproduced or transmitted in any form or by any means without express written consent from the Academy. The timeline for the MIPS program is short. The Quality Payment Program, which is the overarching title in which the MIPS program exists, was only released on October 14, yet the rules begin on January 1st, 2017, so just 2.5 months. So we need to prepare now, and we'll need to prepare throughout much of 2017, and I suspect even into 2018, as we meet the requirements of this program. The key concept is that we are measured in a year. That measurement result is then applied to our fees 2 years later. So the performance in 2017 will affect the doctor's fees or allowed charges in 2019. It's also important to note that this applies to Medicare Part B. It is not a program that includes Part C or Medicare Advantage, nor does it include commercial or medical assistance payers. This program has winners and losers. Basically, there are payment adjustments for physicians that may be up or down, and the amount of those payments will increase as the program goes forward. The MACRA deal that Congress made was to give each of the physicians a little bit of increase in the fee-for-service side, and that you can see is the 0.5% increase forecast from 2016 through 2019. After that, those fees are flat in the fee-for-service fee schedule. Now, it's important to recognize that we might not actually get that 0.5%, that's subject to budget neutrality constraints. And for instance, in 2016, we actually went down a little, although in 2017, we'll go up a little bit, but less than the 0.5. So in 2019, the worst outcome could be -4. The best outcome could be 4%. Now, those may be applied, those high levels are applied only to the worst performers and the best performers, so that many physicians will receive intermediate reductions or increases. For instance, it's possible that a lot of ophthalmologists could see a +1 or +2%, or a -1 or -2. About 12% of physicians will get the -4% in 2019. This program, unlike programs that we had under SGR, is budget neutral. So there must be winners and there must be losers. And the amount of winning will depend on how much was lost. You'll see in this table that there's another group that gets a 5% update, or 5%, not update, but rather bonus each year. That group are those participating in the other pathway in the quality payment program known as alternative payment models. We don't expect that most ophthalmologists will be able to be in those panels, and thus it is not an important part of this discussion. The last row of the table says that there will be up to $500 million each year from 2019 through 2024. Those dollars are given to the very successful, the winners, if you will, in the MIPS program. They will be the best of the best performers, and they could get up to a threefold increase, even up to as much as 12% in the first year. How much of that money is applied to those winners depends upon their scores at the end of the day in the MIPS program. So, the merit-based incentive payment system. This is the main option for ophthalmology and the one that your team and you need to understand. Again, the impacts begin in January of 2019, and it's basically a multiplier, either a slight reduction or a slight increase in the allowed charges that you get. But you're measured starting in 2017. This program consolidates, or you might say replaces, the existing incentive programs, PQRS, meaningful use, and the value-based modifier. But when we say replace, it really just simply combines them, adjusts them, changes them, but they're still there. The incentive payment or the reduction that we get is based upon a composite score. The composite score is based upon our performance in 4 measurement categories, and this is frankly where it gets complicated. We'll get to those categories in a minute, but we need to make sure that everyone recognizes that in the final rule in October, CMS offered some flexibility. Initially, it looked like there were going to be a lot of doctors getting the big penalties, but CMS heard from physicians, heard from stakeholders after their proposed rule in the summer and fixed a number of things. They created what's called Pick Your Pace Transition Plan. Basically, this plan makes it possible for you to have a 0% update in 2019 with no real work. It also makes it possible, if you're ready to go in the MIPS program, to do really well with the upside. However, if you don't participate, you're very likely to be in the -4% category. So this increased flexibility will enable more providers to avoid penalties in 2019. So you need to be there. There are 4 MIPS options for this during the transition year. The first is do nothing. You'll get a score of 0, and that will net the 4% penalty in 2019. For some people, that might be an okay option, but I think that as you'll see in this program, it's not a reasonable option. There are 2 easy ways to avoid that penalty. One of those is to submit some data under MIPS and completely avoid the penalties in 2019. That is a great thing to do and easy. Partially participate in MIPS. You'd remain eligible for small bonuses. They could be very small because many people may partially participate, and thus there isn't much of a negative pool to distribute. And if you're ready, as I mentioned earlier, fully participate in the MIPS program from day one, and you could get up there with the large 4% bonus or even some of the additional money for the very high performers. Great idea to do. In the Pick Your Pace program, there are impacts on your payments, and we'll summarize those again. MIPS, as I mentioned, is a budget-neutral program. The penalties are necessary to make the money for the bonuses. CMS and the Congress didn't want to allocate more or less money in general to this program, but they wanted to move money around between doctors as they succeeded or failed in the program. If few eligible clinicians receive a penalty, then the bonuses will be lower for budget neutrality. And thus, the maximum bonus earned could be less than 4%. And in the out years, the 5% year and 7% and 9% years, those would also be lower depending upon how many successful providers and unsuccessful providers there were. But remember that there's $500 million for exceptional performance. So eligible clinicians who fully participate and gain a score in 2017 of 70 or higher, they would get additional bonuses. It's somewhat amazing that a passing score of 70 would be exceptional in CMS speak. It could be as little as 0.5% on your charges, but again, that was what we accepted for the SGR deal, but could be up to 10%. And that obviously becomes very important if one can qualify. And that's an extra authorization. That's the part of MIPS that's not budget neutral and the part that would be really nice to succeed in. Importantly, some doctors are excluded from MIPS, and they need to know this so they don't waste time worrying about this program or worrying excessively about the program. You're automatically excluded from MIPS by CMS. You don't have to do anything if you see 100 or fewer Medicare patients in a year or have $30,000 or less in allowed charges. For those with optometry in their practices, they are counted as physicians under Medicare and do have to participate in the program with the same rule set. You're also excluded from MIPS if you're newly enrolled during that measurement year. It will be a problem for people that were enrolled in training who then enter the workforce because they will be counted in that first year in practice. You're also excluded if you participate in an advanced APM that meets the required participation thresholds, and that may be possible for a few ophthalmologists. CMS has estimated that 1 in 4 of us will be excluded from MIPS program in 2017, almost certainly because of the new physician or the relatively low volume rules that are in place. Now, back to the measurement. MIPS has 4 categories for our evaluation. They're quality of care, advancing care information, that's the new name for meaningful use, clinical practice improvement activities, and resource use. Each of those categories was included in the law by the Congress. The exact weighting of the scores for each of those categories has been determined by CMS and will change over time. But the initial values you see here are how they'll start for the measurement year 2017. So we'll be measured in each of the categories, we'll get a score, that score will be multiplied by the weight, and then the sum of those 4 weighted scores will then lead to our score from 0 to 100. Again, for 2017, a pass is 3, which is pretty low, it won't take much. Exceptional performance will be at 70. So the secretary has already determined those levels. First year payment adjustments are again based upon how we score in 2017. So a final MIPS score of at least 3 will avoid negative payment adjustments. But if you have 0, 1, or 2, you will have a negative adjustment. Now you can avoid that minus, that 0, and get to the 3 by submitting 1 quality measure or 1 improvement activity. The quality measure can be on a single patient. The 1 improvement activity would be for 1 period of 90 days. Those are really easy to do. Certainly, the Academy's website, this webinar, should give you the information to succeed in those. A final MIPS score greater than 3, yet lower than 70, may receive an incentive payment up to 4%. 70 or more will be eligible not just for the upside of 1 to 4%, but also 0.5 to 10% of additional funding. That's the budget. That's going to represent the amount that's not budget neutral. That's money that would be really nice if some ophthalmologists could achieve.
Thank you, Dr. Repka. I'm Sue Visciarelli, Director of Coding and Reimbursement. The focus of this component of the presentation is to outline options for those of you without EHR. Of the 4 components of MIPS, practices without EHR may report 2. They're identified here in red. Quality measures, which is 60% of your score, and clinical practice improvement activities, or CPIAs, for 15% of your score. As a reminder, it is possible to achieve a bonus without EHR. Your options for non-EHR reporting are claims, or manual data entry into IRIS Registry, or both, or group reporting option via manual data entry into IRIS Registry. Let's begin with the quality category. If the pace you choose is to avoid a penalty, simply report at least one quality measure at any point during the year by manual data entry into IRIS Registry or claims-based reporting. Participants who successfully report at least one measure will get a MIPS score of 3 out of 100. All Academy members should be able to accomplish this and avoid penalties in 2019. However, if you want to be eligible to earn a bonus under MIPS, you must earn a total score higher than 3. To do so, you will need to report on more than one quality measure. For each quality measure reported, physicians will be awarded at least 3 points just for successfully submitting data. If you report on several quality measures in 2017, even if it's just for a period less than 90 days, you could potentially earn enough points to qualify for a small bonus in 2019. One downside of claims reporting is that it must be done in real time. And remember, if your claim is denied, your MIPS reporting is denied also. IRIS Registry reporting assures CMS receives the data. Should you choose to maximize your quality score for claims-based reporting, you must report on 6 quality measures for a period of 90 consecutive days successfully for a minimum of 50% of your qualifying patients. Physicians reporting by claims would only report on Medicare Part B, Medicare as a secondary payer, and Railroad Medicare patients. Of the 6 measures, at least one must be an outcome or high priority measure. Plus, you can earn bonus points for additional outcome or high priority measures reported. Should you choose to maximize your quality score by IRIS Registry manual data entry reporting, you must report on 6 quality measures for a period of 90 consecutive days successfully for a minimum of 50% of your qualifying patients, regardless of their insurance. Of the 6 measures, at least one must be an outcome or high priority measure. Plus, you can earn bonus points for additional outcome or high priority measures reported. Or you can report both claims and IRIS Registry reporting to assure CMS receives your data. Dr. Bill Rich, the Academy's past president, refers to this as the belt and suspender method of reporting. The majority of ophthalmologists will be evaluated for quality based on the quality measures they report for MIPS and their performance rate on those measures. How does CMS determine how many points will be awarded for each measure? They compare you to performance rates from the 2015 reporting year. Essentially, they take the performance of all physicians that reported on a measure from 2015 and break those performances into deciles. Your 2017 performance score will be compared against those deciles, and you will earn points according to which decile your 2017 performance rate falls. If you perform perfectly on a measure, meaning you get a performance score of 100%, you will earn the full 10 points. Note that performance rates are different than reporting rates. CMS will award you 2 points for each additional outcome measure reported beyond the one required outcome measure. They will also award you 1 bonus point for each measure that is reported using a registry, such as Iris Registry manual data entry. What quality measures does Iris Registry offer? For physicians without EHR, Iris Registry plans to offer 48 measures from which you may choose 1 to avoid the penalty or 6 to go for the bonus. Of the 6 you select, at least 1 must be an outcome or high priority measure. Note, Iris Registry offers 28 outcome and 10 high priority measures from which to choose. This slide identifies the number of outcome and high priority measures by specialty. There are minor changes to the existing measures. The primary change is the addition of the new ICD-10 codes impacting diabetes, macular degeneration, and primary open-angle glaucoma. Iris Registry, however, is planning a few changes. As the cataracts measures group will no longer be an option for reporting under MIPS, Iris Registry is moving away from the 2 burdensome measures that would require post-surgery surveys of at least 50% of your qualifying cataract surgeries. Measure 318, falls screening for future risk, is moved from manual reporting to EHR only, adding Measure 1, diabetes A1C poor control to EHR reporting, and for neuro-ophthalmology, adding Measure 419, overuse of neuroimaging for patients with headache and normal exams. For the first year of MIPS, physicians are not required to report on measures across a set number of quality domains. However, as previously stated, you will report on at least 1 outcome or high priority measure or more for bonus points. This and the following slide indicate which can be reported via claims or manual data entry into Iris Registry. Again, to avoid a penalty, report 1 measure several times via claims or manual data entry into Iris Registry, or both. To maximize the opportunity for a bonus, however, report 6 with at least 1 of the 6 identified as an outcome or high priority measure. Here's an example. If I were a retina specialist without EHR and I hope to qualify for a bonus, I might pick the following 6 measures. Diabetes A1C poor control, which is an outcome measure. AMD dilated exam. Diabetic retinopathy, communication with the physician managing ongoing care, a high priority measure. Diabetes, dilated eye exam. AMD, the AREDS study, and tobacco use screening. For claims, I'll report on all 6 measures on at least 50% of my qualifying patients, but as a precaution or to ensure success, I'm going to report on all my Medicare Part B, Medicare as a secondary payer, and Railroad Medicare patients for a minimum of 90 consecutive days. Manual data entry into Iris Registry, I will report those 6 measures on all my patients for 90 consecutive days, regardless of their insurance, or I might choose to report both options, claim and manual data entry through Iris Registry, just to make sure I am successful as possible. If you report using 2 different mechanisms, CMS will take whichever one is most successful and results in the highest MIPS score. Like the retina example that I just gave, Examples of which measures each specialty may choose are under development and will be posted to the Academy's website. If the reporting option you choose is to enter your data manually into IRIS Registry, measures on this and the following slide are even more potential measure options. These measures were developed by the Academy in conjunction with the specialty societies and are pending CMS approval. We expect to receive notification of CMS approval in April or May of 2017. Remember, unlike claims, manual data entry into IRIS Registry does not have to be done in real time. Therefore, it's okay to wait for approval before reporting begins. What are the due dates by which the measures must be reported? For those who submit via claims, all your 2017 data must be processed by CMS by March 1st of 2018. If manual data entry is the best possible option for those of you without EHR, sign up now for IRIS Registry if you haven't already. Manual data entry must be completed by January 15th of 2018, so IRIS Registry can submit on your behalf by March 31st. Now we'll move to the new category called Clinical Practice Improvement, known as CPIA. Again, if you only want to avoid penalties next year, you can report on one quality measure as we explained earlier, but you also have the option to report on one clinical practice improvement activity. If you want to earn a small bonus, you would need to report on more than one CPIA. If you are participating fully in MIPS and seeking to maximize your score, you will need to complete a sufficient number of CPIAs for a 90-day period in order to reach 40 points. How do you get 40 points? The activities have been identified by CMS are weighted as high or medium. The high activities are worth 20 points and the medium activities are worth 10 points. So you could report on 2 high-level activities, 4 medium activities, or a combination of both in order to reach 40 points. However, small practices are the exception. For them, the points are doubled. Practices with 15 or fewer eligible clinicians need only report on 1 high-level activity or 2 medium-level activities in order to get full credit for the clinical practice improvement category. In order to report a CPIA, you must attest that you have completed that activity. Attestations can be submitted directly to CMS on the CMS attestation website, which may be similar to the Meaningful Use attestation website, except that you'd only be required to say yes or no that you have completed the activity. If you report using IRIS Registry, you have the option to attest to IRIS Registry which activities you completed, and IRIS Registry will submit that data to CMS on your behalf. There are about 90 clinical practice improvement activities that CMS has identified. Some of them have no relation to eye care or the workflows of ophthalmologists, but many are relatively easy to achieve. Here are a few examples listed on this screen. Note that participating in a registry counts for a number of activities. So if you're participating in IRIS Registry and meeting the activities on the screen, you will automatically get credit for CPIA. A relatively new concept in 2017 is group reporting. You cannot report via group from claims, but you can from manual data entry into IRIS Registry. The benefits of group reporting are listed below, and here's an example. If my practice consisted of 2 comprehensive ophthalmologists, a pediatric and neuro-ophthalmologist, it may be a challenge for each physician to find 6 unique measures to their specialty. But when we report as a group, the 6 measures can encompass 1 or 2 from each specialty and the remaining comprehensive ophthalmology measures. What are the IRIS Registry deadlines for MIPS? If you switch from paper to electronic health records, you must sign up with IRIS Registry by June 1st, 2017. The web portal registration deadline to report manual data entry is October 31st. The submission deadline for claims-based reporting is January 15th, and the data release consent form deadline so that IRIS Registry can report on behalf of your practice is January 15th of 2018.
So what has the Academy done in advocating for our doctors this year as the MACRA program has been rolled out, as rulemaking has gone on? We've had staff at CMS, we've had staff writing comment letters, the longest comment letters we've ever written. We've had lobbyists on the Hill working on this issue, trying to explain to members how onerous some of the burdens may be. There are some victories that have come this year during that. There is the increased flexibility that was added in the final rule with the Pick Your Pace program. There are expanded exemptions that were there mentioned earlier in this webinar. It's really important for the pediatric ophthalmologists, those that don't see seniors in Part B, doctors who only see a lot of Part C and little Part B, they could be excluded. And that would be, I think, good for them in the early years as this program works out a lot of kinks that are certainly to be there. The other victory was the neutralization of the resource use category. This has been a most problematic area for CMS. They have done quality resource utilization reports in many parts of the country. These QRUR reports are confusing, inaccurate, and not risk adjusted or subspecialty adjusted and create more confusion. So elimination of the resource use category for 2017 is a great thing. The clinical practice improvement activities have been made easier. They've reduced the number of activities a provider must complete to get full credit. For groups under 15 providers, for instance, you need to do 2 activities for 90 days. You should be able to knock that out quickly and get those points in that category. The reporting period has been made much more flexible from a full year to 90 days, including that for the advancing care information category. That difficult, meaningful use area has long been a bane of contention for ophthalmologists, and this has made that, I think, much better. There will be fewer advancing care information requirements, so it should be easier to succeed in terms of that category as elements. There also is a lower quality reporting burden. It reduces the percent of applicable patients on whom physicians must report quality measures to 50% rather than from 80 or 90%, which were in the proposed rules. These are truly victories done at the grassroots and at the lobbying level in DC. We will spend much of 2017 working on further improvements in this program as we move into the 2018 reporting year and the 2019 reporting year and so on.